Okay, I'd like to thank you all for taking some time out tonight to go over some new coding CPT changes that will take effect here in a couple weeks. First of all, I want to make sure that you understand these are examples and they're not a substitute for provider-specific clinical judgment, and each individual patient is unique, and providers need to use their own judgment. So this presentation is only for the new guidelines. It's only for January 1st, 2021 when this takes effect. Until then, you want to use everything the same way you've been using it. This is the quote from Dr. Holloman, who was on the committee that helped develop these. The whole point was to have people not document stuff that was not necessary, not relevant to clinical management. So most of this information comes directly from the AMA tonight. I do need to make sure you understand CPT is a registered trademark of the AMA. If you're looking for some resources, there's some good ones out there. The AMA has the best one, I think, here, the compendium. You can get at the bookstore for the AMA or Amazon. And then there's some good wall charts that are also available at the AMA or on Amazon. And for pediatricians, the AAP has a good book here, Evaluation Management Coding, that you can get directly from them. So where are we today? Well, it's been almost 25 years since we've made changes to these coding requirements. The documentation requirements today, many feel, are too excessive and don't contribute to the chief complaint. We use time, but very outdated rules, and because it must be face-to-face, and over half the time has to be counseling and for coordination of care. So what are we going to do here in the future? Well, they've made some major changes to all the CPT codes for E&M. They've not made changes to inpatient or observation codes. 99201 has been deleted. There's changes to medical decision-making table, which are critical to determining the level of CPT. And then there's typical changes or changes to the times associated with each one of these E&M codes. And now you get to choose between time or MDM and not necessarily the volume of your documentation. And there's some changes to your time for extended visits, which we'll go over at the end, which are very important. There's no longer a requirement for a specific level of history and exam. History and exam only need to be relevant and pertinent to the reason for the visit. In the past, we've been documenting all this stuff that was probably not pertinent just to support the E&M level. So all of this stuff, that's gone. This is what the new guidelines will say. This is what it says right now: a detailed history, a detailed exam, medical decision-making. In the new CPTs for 2021, it requires a medically appropriate history and exam and a moderate level of medical decision-making. And we'll talk about these times if they've changed also. So this is what they used to use when they were reviewing your charts. That's gone. We're going to be left with this: 4 levels of medical decision-making, 4 levels of time, and we'll go through them one by one, but this is what you're going to start using for 2021. So medical decision-making, that's going to determine most of what you do. Right now, CMS announced 2 weeks ago that they are going to follow these guidelines from the AMA. Commercial payers, most of them do follow CPT guidelines, but what I would suggest is you check with your payer. For North Carolina here, Blue Cross of North Carolina, they do follow CPT, and they're going to follow these new rules. This is directly from them. So the thing that's going to determine your E&M code is your problem. And all of these things would define your problem: disease, condition, illness, injury, sign, symptom, question, complaint, finding. But you do not have to establish the diagnosis at the time of the encounter. And that's something critical that we'll build on. And again, you need to remember. So you also need to understand a problem is not addressed if you're not managing it. If you just say cardiology is managing CHF, no change in treatment, that's not part of your medical decision-making. You order something like a referral for dermatology for a full skin body check, but you didn't do anything for that. You didn't do a body check for skin, then you really can't include that either. And you do not just simply include problems in the medical record, again, unless they were addressed. They're part of the problem that the patient is there for. So again, we're going to have just a medically appropriate history and physical, and we're going to have these 4 levels of MDM, and then again the 4 times that we'll look at. So let's look at the MDM here first, the medical decision making. Well, none of that's really changed. We still only have 4 levels: the 202s, 212s, where there's minimal type management, amount of data, and minimal risk of complications. Then, of course, we go to the low complexity, which are the 203s, 213s. Now there's limited options and a limited amount of data, and there's some lower risk of complications. And then, of course, we go up from there to the 204, 214s with multiple options for management, moderate amount of data, and moderate risk. And then, of course, the highest complexity, the 205s and 215, where there's extensive amount of data and high risk of complications. So those are going to be your 4 levels of medical decision making. But to get to those 4 levels, you're going to need to know the three elements that make those up. Number one is the number of problems and complexity. Number two is going to be the amount of data and or complexity of data reviewed and analyzed. And number three is going to be the risk of complication for morbidity or mortality and patient management. You put those three together and you're going to come up with which E&M code you choose. It is critical to remember you only need to satisfy two of these three elements in any one of these levels of MDM. You do not need to satisfy all three. This is the chart you're probably going to want to remember and keep with you. It has a lot of examples, and it does kind of lay out the different columns. We got three different levels, like I say, three different elements here. You need two of these three elements. We're going to build this chart one by one. It doesn't include everything, though, but it gets you a good foundation for what you need to make your medical decision coding decisions from. So let's first start with element one, the number and complexity of problems. Again, remember, the diagnosis does not have to be established at the time of the office visit, but you're going to need, if you satisfy just the number and complexity of problems for moderate, you still need to satisfy moderate in another category, or same thing. So you're going to need two of these three categories. We're going to start with the first category here, the number and complexity of problems. This is what the AMA has defined, and we're going to build these one by one. So remember, a 99211 does not have a minimum time or specific medical decision making because it's a service performed and physician presence is not required. So this is something like where you do a weight check that you scheduled, a blood pressure check. Again, not something where the patient just drops in. This is something you've set up. A suture removal that's done from another office where the sutures were put in, an asthma or diabetic counseling that you're not doing just every week or something like that, non-repetitive, and then dressing changes for an abrasion or injury. So again, there is no medical decision making for the 99201. So your first category is going to be the 202212, and these are going to be your straightforward. They're going to run a definitive and prescribed course. They're going to be very transient. So cold, tinea, uncomplicated insect bite, diaper rash. Those would be examples. Now, as we move into the low complexity, the 203213s, we're going to have different categories here. So if you have two of those self-limited or minor problems, like you had tinea and an insect bite or something, that would be low complexity. If you have a stable chronic illness, a stable is, first of all, chronic is defined if it's going to be lasting more than a year, and there is some risk of morbidity without treatment. They're not at their goal, even if the condition hasn't changed and there's no short-term threat to function. So if you set goals for their hypertension, their diabetes, and they're not at that goal, even if it's not going to hurt them in the immediate future, it still is not considered stable. Then an uncomplicated illness or injury, this isn't going to include most of the things we cover, new and short-term problem, low risk of morbidity, little or no risk of mortality, full recovery. So things like cystitis, allergic rhinitis, otitis, pharyngitis, ankle sprain. Where we get a little more detail, and in this category, which is the moderate, we're actually going to have 5 different examples that the AMA has given us. So one undiagnosed illness with an uncertain prognosis. Well, what's a good example of that? Like a breast lump or a new neck mass. Then you're going to have your acute illness with systemic symptoms. So this is going to be something like COVID, colitis, pyelo, pneumonia, spontaneous breathing, something that's evolving systemically. It's not just localized. And then as you just saw in the low, we had the uncomplicated injury. Now in the moderate, we have the complicated injury. You got to look at a body system that's not directly part of the injured organ, or it's an extensive injury, or there's multiple treatment options. So something like a head injury with loss of consciousness would show up in this category. And then the other 2 categories for moderate, when you're doing 2 or more stable illnesses. Again, this is going to be very common for you when you're dealing with diabetes and hypertension, or a patient with ADHD and asthma. They're coming in for 2 stable chronic illnesses. That's going to be a moderate 99204-214. And then exacerbation that's mild, or side effects from a chronic illness for treatment. So again, this is acutely worsening. It's going to require additional supportive care. It's going to require attention to treatment. There's no consideration for hospital care. Again, a mild to moderate exacerbation of asthma, social anxiety, and they're not able to leave the house now, ADHD with tics, secondary to treatment, uncontrolled diabetes or hypertension. Again, any of these are going to be your moderate level of complexity for problems. And then, of course, your high is going to be pretty straightforward. It's going to be your chronic illnesses with exacerbation, COPD, asthma, CHF with severe exacerbation, anything where there's potential for hospitalization or something that's posing threat to life or bodily function, acute renal failure, depression with suicidal ideations, diabetic ketoacidosis, COVID with a lot of symptoms. Any of these things, of course, are going to be pretty straightforward for high level of complexity. So let's look at these again. Again, the self-limited problems like diaper rash, simple cold, uncomplicated insect bite, these are all going to be low if you have 2 or more of those. Your stable chronic illnesses, so your well-controlled ADHD, hypertension, diabetes, all of this is considered low. They're stable. If you have just one of them, again, you're just treating one of them at a time, and then your uncomplicated illness or injury. Your moderate, again, we've got the 5 different categories: the undiagnosed illness with uncertain prognosis. You've got the acute complicated injury, the head injury. Then you've got the chronic illness with side effects of treatment like ADHD with tics, ACE-induced cough, statin with joint pain. Again, these are all moderate. And then anything that goes systemically, COVID, colitis, pyelonephritis, all of those things are systemic illnesses, and they're going to be all moderate. And then again, if you're taking 2 or more chronic stable illnesses like hypertension and diabetes, you're going to qualify for moderate number of problems. And then again, the chronic illness with mild exacerbation like asthma, or the social anxiety, or the uncontrolled hypertension or diabetes. And of course, the acute high incident problems that require hospitalization or severe side effects, these things would quantify as your high level of complexity, and they would satisfy element 1 in this table. So there are multiple symptoms that sometimes patients have that cluster around a certain diagnosis, but they're not necessarily a unique condition. For example, you got a low-grade fever, body aches, postnasal drift with cough and some shortness of breath. Well, that can be acute uncomplicated. That's a low MDM, because if you do a URI and don't reference, you're considering this thing to be any kind of more complex or systemic illness. However, if you're concerned about pneumonia, or you're concerned about something else, and you document it and you make that diagnosis a possibility. Again, you don't have to make the diagnosis at the encounter. You just have to document that you're considering it. Now you have a moderate level of MDM. Sometimes there's going to be an extensive differential. And you still may just come up with something that's not very serious. Again, if you have to rule out a lot of serious things to get to a simple diagnosis, that's still a higher level of MDM. So example, COVID versus bronchitis. Well, if you're thinking COVID, but you really don't document anything, you just treat this patient as bronchitis, then you've got an acute, low, uncomplicated illness. But now, if you've got a patient coming in, you're not sure COVID versus bronchitis, you send out a PCR. Now your problems is moderate because you've got an acute possible illness with systemic symptoms. You don't have to make the diagnosis. You send out the test. You show that you've been thinking about it. And then comorbidities are important because they can sometimes, again, just because they have comorbidities, you don't get credit for multiple decision making unless it affects the problem they're coming in for. So a patient comes in for an ankle sprain. Well, now you've got this patient with all these different all these different conditions. You've got to look for, well, hey, if I use an NSAID, the patients on blood thinners can't do that. There could be worsening of their edema, the lack of mobility, fluid retention. So versus the patient that didn't have anything. So an ankle sprain for them was just a low acute uncomplicated. But for this patient that has all these comorbidities that you have to consider as part of the treatment, now you have a moderate acute complicated because you're looking at body parts outside of the injury. Element 2 is the data, and there's a lot of gray areas here, and I'll show you some of those, and some of this you're going to have to use your own clinical judgment. They tried to get away from numbers, but then they added all these threshold numbers in here, which is kind of frustrating, but we'll go through that because it can be a little confusing. So there's 3 layers of data. One is going to be the stuff that you pretty much do all the time: documents, labs, x-rays, notes, other testing, or independent historians. But remember, each unique test is counted as one number to meet that threshold number, but referring back to your own notes does not count. We'll talk about this in independent interpretation of tests. And then, of course, if you discuss managing the patient with anybody outside of the office that's a healthcare provider or somebody that's an appropriate source, that would count too. So again, the data, like I say, the medical records test, we all know that. Any kind of interprofessional communications, like from specialists, all that stuff's going to be review of data. But when you order a test, it's ordering of each unique test. So you order these 4 tests, you get credit for 4 tests. The order and review of these tests, though, are counted as one. If you order it in one visit and you review it in the next, it's still only counted as the order for the data for that first time when you ordered it. Order and review are counted. Now, if you review a test that's not done as part of your encounter from an outside source, that counts as well. So just to clarify that, you order a test on December 1 and you do a follow-up on December 8th, you don't get credit for the review on the 8th, you get credit for the review on the 1st. So what's not included in MDM? These services that are reported separately. So if you use a 0.25 modifier for a procedure or service, or a 0.59, anything that you bill separately to that E&M code is not going to be considered part of the MDM. So you're going to get paid separately for that, like draining an abscess, joint injection, spirometry. If you do x-rays, in your facility or bone densities and you bill for that, you're not going to get credit for that. So if you bill for a CPT code to encounter, it's not counted in time. By that definition, though, that excludes all of these rapid tests, which I have a little bit of an issue with, and I'll show you why that really doesn't matter. But if you use the actual definition from the AMA, it does matter. So laboratory test, each CPT code is one unique test. Every panel is one unique test. You may have 6 or 7 things in that panel, but that panel is considered one test. So you order a hemoglobin A1C, a CBC, a TSH, BMP, that's 4 tests. As we'll see in the complexity data category, that's going to satisfy a moderate. And again, these in-office procedures that you're going to bill separately, depression screening, advanced planning, joint injections, foreign body procedures, earwax removal, those are separate CPT codes that you're going to bill separately. Those don't count, and your staff time does not count at all. So there is no data in the straightforward, so we're not even going to worry about that. Again, the 99212, where our data really starts in the low category, 99203.213. And there's 2 different categories here. You need either one of these categories. You do not need both. And one of them is just going to be reviewing notes or reviewing unique tests or ordering each test. And it can be any combination. It can be 2 notes. It can be ordering 1 test, 1 note. It can be reviewing 1 test and reviewing 1 note. Whatever satisfies 2 of these will get you that category for low, moderate, for low data. Category 2 is an independent historian. So if you have to use an independent historian, this would be especially for pediatricians, family member, witness, other individual, that when your patient can't provide a good history and you need it, again, you must judge that you need to have that history and you have to get it from a secondary source, then that is an independent historian, but they have to provide new info. If there's a conflict where you have 3 or 4 people trying to give you information, there's a conflict and you don't get any useful information, but they're still you're querying them, that counts as well. And then again, your typical patients are going to be your infants, your young children, some of those with neurologic issues, dementia, delusional. Your spouse does not count. If a husband doesn't want to tell something and the wife has to tell it, that doesn't count. So, you know, a pediatrician has to call a teacher because the patient has learning disability and ADD and wants to see how the kid's doing. That counts. This is the decision tree. Remember, for low level, we only need one of the 2 categories. So any one of these where we meet one of these 2 categories, we get credit for low level decision making for medical management. Moderate, we've actually now got 3 categories. We've moved the independent historian up into the data section here, but now rather than 2, you need to have 3 of these. And then we've added this independent interpretation, which I'll review in a second, but this is where you review an outside tracing or an x-ray or something like that hasn't actually, that you're not relying on someone else that's actually read it or that report and you did not bill for it. And then discussion, category 3 again is if you discuss this with anybody outside the office that's pertinent to the care of that patient. So this independent interpretation is a little bit confusing, but basically this is something that you didn't bill in your office and you don't have the ability to get a report or whatever at the time you're reviewing it, and it impacts your decision making. So again, example I would use here is I have a patient that I just did an EKG on, came with chest pain, has a right parietal branch block. I don't have an old EKG. They've got old flipped interior T waves. So the patient shows me an EKG that they have scanned into their phone but doesn't have an interpretation. I see the same changes there. So I know these changes aren't acute. That plays into my decision making. That qualifies as category 2. So I've met my decision making for moderate. Another thing would be if you could do a wet x-ray read before your radiologist, that would quantify. But if you read the radiology report and pull up the x-ray, that doesn't count. If a computer has EKG computer interpretation, that doesn't count. So your discussion for category 3 is with any external source, a specialist, another primary care, a lawyer, a police officer, again, the teacher we showed, case manager. Anything that requires that to help with that care that's outside of your office would qualify as that. So again, all you have to do is meet one of these 3 categories. So you see all the green here. As long as you meet one of these 3, if you meet none of them, you would go back to the low level of MDM. And the high is very similar to the moderate. They use the same categories, except now you have to meet 2 of the 3 categories. In moderate, you only had to meet 1. So again, if you meet 1 here, you have not met high level of MDM, you're back to the moderate. If you've met 3 or 2, you have. Again, this just shows you how they transformed these, where they moved the independent historian up for the moderate, and then you need 3 rather than 2. And in the data for the high, you need to meet 2 of these 3 categories. So how would you credit this data? A 3-year-old, comes in the pediatrician's office, or an 85-year-old with dementia comes in with their daughter and follow up for an urgent care visit over the weekend. Provider read the note, he reviews the CBC, and he obtains a history from the dad or the daughter of the demented patient. Well, moderate data. You've reviewed a note, you reviewed a test, and you got an independent historian. The last element is risk, complication, and patient management. First, make sure you understand morbidity is a state or illness or functional impairment that is expected to be substantial duration, during which function is limited, quality of life is impaired, or there is organ damage that may not be transient despite treatment. Shared MDM is very important because this involves eliciting patient or family preferences. Sometimes when you have to make a decision for hospitalization or other care, you're providing patient and family education, you're explaining the risk and benefit of these management options. So what this is going to come into play is when you, again, we're looking at the risk of potential treatment that from the patient's presenting problems. So it not only includes the management options we choose, but in some cases, it's going to consider those that we considered, but after shared medical decision-making with the patient or family, we decided not to pursue, like hospitalization. So if you do shared medical decision-making with the family, and even if you don't have to hospitalize or you don't have to de-escalate care or make them a DR, it's still part of the medical decision-making because you did the shared MDM. So again, an example would be hospitalization. Again, for a care that has a good care system at home, you talk to the patient's family, they feel like they can take care of them home instead of the hospital, that would count as potential for hospitalization. Same thing, psychiatric patients really depressed, but has a good support system. Or again, somebody with advanced dementia that really probably could go in the hospital, but really is at end stage, and the family decides they want to take them home. So in category risk, element 3, we have the straightforward, again, minimal risk, nothing with tinea or diaper rash that's going to cause any kind of morbidity or mortality. The low risk, again, we've got the things like the rhinitis, the URI, pharyngitis. There's a lower risk of morbidity. So where we get into the examples that the AMA has given, and again, remember, they don't include everything in here. So I'm going to show you that in a second. But the examples they left is any prescription drug management, refill or new, counts as moderate risk. So if you write a prescription or refill a prescription, you've got moderate decision-making for risk for category 3. These other things about surgery are really not pertinent a lot of times to primary care, but if you have to make some decisions are clear for surgery, again, if it's a major surgery, there's no problems, or it's a minor surgery, there could be some problems. But the thing that's more important here is the diagnosis limited by social detriments or determinants of health. And this is like homelessness, poverty. This is things where they have learning disabilities, child and welfare custody, things that, again, when you do your MDM, these are all the Z codes I could think of, but you can probably think of some other ones that you have to use. So you have to use this code. But just like comorbidities, they have to be part of the decision making. Just because they are homeless or just because they are poverty and that, it has to play into your MDM if you're going to count it. So again, if you do that, you automatically qualify under the third element, risk for moderate decision making, 99204-214. But remember, you need 2 of those 3 elements, so you have to get moderate in either the number of problems or the data. And then the high, this is, again, hospitalization. Remember, we just talked about shared MDM. You don't have to necessarily admit, but if you had shared MDM, that would count. Same thing with DNR. Again, any decision for major surgery, or if there's an elective procedure where there's a huge risk, like surgery with poorly controlled diabetes. And then this one is the most one that gives some people trouble. Drug therapy, including requiring intensive monitoring for toxicity. All of these are considered high. So what is this drug therapy? Well, it's a drug that has intensive monitoring as therapeutic agent, but has the potential to cause serious morbidity or death. So the monitoring is performed for the assessment of these adverse effects. It's not for the therapeutic efficacy. And the interval should be a generally accepted practice, but sometimes you have to make patient specific in some cases. So the example they give is the short-term intensive monitoring of electrolytes and renal function of a patient who is undergoing aggressive outpatient diuresis. You got a congestive heart failure patient, you don't want them in the hospital, but you want to do some outpatient diuresis. You've got to watch their kidney and their potassium. So you have to do very close follow-up on that. So this intensive monitoring can be long-term or short-term. The long-term has to be no less than quarterly. It has to be done through a laboratory test or imaging or physiological test. It cannot be done by history and examination, and it has to be part of the MDM. What doesn't count? A good example is monitoring of glucose during insulin therapy. Yes, they could be having hypoglycemia, and that may be a concern, but your primary reason for monitoring insulin level or glucose levels in insulin therapy is for therapeutic effect. You have a patient, you check annual electrolytes, renal function on a diuretic. This doesn't meet the standard of checking every quarter. And then if you do check them every quarter, this is overdoing it because the standard for checking a patient on diuretic is probably not every quarter, unless there's special circumstances. It's more like twice a year or once a year. Some examples in pediatrics: minimal risk, tell the patient they're risking plenty of fluids, diaper ointment, superficial wound healing. Again, our low is our over-the-counter medicines, remove sutures, physical language, occupational therapy, and then our moderate and high, very similar examples. So remember, this is critical to remember, again, one of these critical things. It does not, the final diagnosis you come up with does not determine the complexity or risk. If you have to do an extensive evaluation to get to a sign or symptom that's not highly morbid, it's still considered a moderate or higher level of risk if you had to go through that and rule out those higher acuity illnesses. So if you have multiple problems of a lower severity, again, in aggregate, if you put them all together, they actually may be a higher risk. So example, fever, body ache, sore throat, nausea, vomiting, diarrhea. You've got 6 different complaints. Well, all these complaints by themselves are pretty much acute, self-unlimited. They're going to go away, usually with some minimal treatment of that. However, now if you're looking at COVID versus flu versus UR versus gastroenteritis, you've got 4 different levels. You've either got a self-limited, acute with systemic. So you've got, it's all, and again, about what you document here and what you consider. So again, if you're just considering this is flu, then probably you've got a low level. If you're considering this is COVID, then you've got a moderate level, because now you're looking at systemic symptoms. So remember, you've got to be able to document what you're thinking, and it doesn't count if you infer it, and I'll show you that in a minute too. So just to refresh this chart here, and I want to show you this for moderate is not all inclusive. They give these as the 4 examples, but you got a patient with chest pain that comes in that has a high enough risk that you think you need to order a stress echo to rule out cardiac. That's an acute illness that's got some systemic symptoms. And even though you didn't prescribe anything, your risk is still moderate. You don't necessarily have to meet these 4, but if your risk for that diagnosis, which you're looking for coronary artery disease, is moderate, same thing with TIA, where you're trying to rule out a stroke, and you may not do anything, they may not prescribe anything except order the MRI, so you don't meet any of these other categories, your risk of complications and morbidity is moderate. So again, don't just rely on all 4 of these. A patient presents for follow-up after treatment of otitis. The TM is white with evidence of malaffusion. You tell them, hey, this is going to get better, nothing else you need to do. Straightforward. Self-limited problem, no data, it's going to get better on its own. Now a patient comes in with acute right ear pain. You have a diagnosis acute otitis media without rupture. So now you have an acute illness. So now you've got low MDM there. There's no data. You prescribe a drug. So now you've got one in the low, you've got one in the straightforward, you've got one in the moderate. Well, prescription drug management, remember, is moderate risk. Column 3 only. You need 2 of 3 columns. So this would be a low medical decision making, because your moderate risk would actually go back. You have to have 2 of 3, so you default the highest one back to the next level, which would be your moderate risk would actually translate into low risk in this case. Now, this is one thing where this chart falls apart too. You got these patient comes in with all these self-limited, stable, and uncomplicated illnesses. ADHD, tinea, they've got allergies, they hurt their knee, and they got a mole. All of these, if you look at the chart, are acute uncomplicated illnesses, 1 stable illnesses. Well, everywhere in this chart, they say, hey, 2 or more of these quantifies as you the next level. 2 or more of the lows quantifies you for moderate. So in my estimation, when you have 2 or more of these uncomplicated illnesses and energy from injury, that is going to move you to the moderate. And again, that chart is not to be all inclusive, so you have to use some common sense. And again, I think if you get 2 or more uncomplicated illnesses, you've moved yourself up to the moderate. Whether or not you prescribe drugs or not, then that would determine your ultimate outcome. So another thing, documenting complexity here. Kid comes in, fever 103, confused, cough over the weekend. Dad said fever responded to Tylenol, has been acting sick in daycare. So you've got this kid, fever, confusion, vomiting. This could be at least moderate risk in most cases, but the provider says, hey, this is otitis, all the symptoms related to otitis, prescribes antibiotic. So if you're concerned about this complexity and you don't document, you just say it's otitis, everything's related to otitis, then you've got a low level of MDM. Whereas if you're looking at this as more potential systemic problems, which would be a moderate MDM, you have to document it. If you think it, you've got to document it. It's not inferred or implied. You have to document what you're thinking. So again, you've got that acute uncomplicated illness, you prescribe drugs. Remember, you need 2 of 3. So if you have 1 in each category, the highest one is going to drop down to the next category. So this would be 2 lows, which means that would make that a low complexity. Now, if he documented that this was an acute illness with systemic symptoms, now you prescribe drugs, now you've got a moderate level. So that's how that would change. Somebody comes in with worsening asthma, they've been using their nebulizer, they're not using any other inhalers, you do a spirometry. Again, if you're billing for that spirometry, it's not going to be part of your data. You give them a sample and you give them a diagnosis of mild persistent asthma with acute exacerbation. Well, you've got a chronic illness that exacerbated, you got really no data, or if you want to count, spirometry, if you're not billing for something, you could count that. And you've given them prescription drug, but really you gave them a sample. Does that count as prescription drug? Yes. Anything where the thought processes and the risk would remain the same, whether you write it down or you give it to them, is considered a prescription drug. So again, these examples are not a substitute for your clinical judgment as a provider, and each individual patient is different. So let's run through a little scenario here with a migraine patient. Having migraines for a while, been taking a lot of Maxalt recently. You say, hey, it's time for some preventative treatment. So you put them on Topamax. Well, you've got a chronic illness that's mild exacerbation. You've got prescription drug management because you've given them refilled their medicines and added Topamax. That's a moderate level. Same patient comes back. They're happy with their results on the Topamax. They also mentioned they have allergic rhinitis and Astelin. You give them some Astelin nasal spray. So you've got a stable chronic illness. Now they're better because they're on the preventative things, and you've got an acute complicated illness. Again, the way this table works, this would quantify as low in number of problems and complexity. You gave them the prescription drug. So again, you've got 1 here, you've got 1 in no data, and then you've got 1 in the risk, in the moderate. So you've got 1 in each category, low, straightforward, and moderate. This goes back to the low. So in this case, this would be a low level MDM. Now they come back in, and in addition to the postnasal drainage, said, hey, my insomnia is doing good. I need my trazodone refilled. Now you've got 2 or more stable chronic illnesses. You're giving them prescription drugs. So now you've moved up to the moderate level. Patient comes in, simple thing, could take you less than 5-10 minutes. For asthma and ADHD, ask them some questions. Everything's doing well. You refill their asthma and Adderall. You tell them to come back in 3 months. 2 or more stable conditions, moderate level because you did prescription management. 2 of the 3 were met. Now, each disease can by itself, remember I said that doesn't determine the final diagnosis for CPT. So let's look at asthma. If they just come in for a care plan review by a nurse, that's a 99211. If they come in because they want to ask some questions about using the beta agonist before exercise, that's a 212. And if they're stable and you're just refilling their medicines, that's a 213. Now they come in your office, they're having a little worsening of symptoms. You make some changes, add an inhaled steroid, that's a 214. And of course, if they came in to your office and they were really doing bad, wheezing really bad, you gave them some nebulizers they weren't doing, you had to put them to the hospital or to the emergency room. Now you've got a chronic illness that threatens body life and function, that's a high, and then you refer them for hospitalization, that's high. So that diagnosis could be one of any of those 5 different or 4 different levels of MDM. Do parents count as independent stories? Yes, they do. There's no age limit, but remember, you have to determine that who's ever given this independent history, whether it be an adult or for an adult or for a kid, it has to be something that's necessary. And again, if you bill for a rapid test like this, does it count as an order review or both? Well, if you look at the AMA definition, they say if you're billing for it separately, it doesn't count in your MDM, which doesn't make sense because that's why we're doing these tests. So we're doing all these tests to determine what to do with the patient in our office. But in reality, it doesn't matter. The only time it's going to matter is if for some reason you ordered 3 of these tests at one time, because you're going to be dealing with an acute uncomplicated illness with these tests. You're either going to prescribe drugs or not prescribe drugs, so you're automatically going to be a low. Again, with COVID, I think it becomes a different thing. If you have to do a COVID, a strep, and a flu test, then again, you're dealing with something systemic. So I think that's where you would go to you would consider this a moderate number of complexity of problems anyway. So again, I don't think the test matters. Guess basically what I'm saying for this. You're going to end up with a moderate or a low depending on what you do. So if I order a CT scan on the 1st, have them come back on the 8th, does that count as a review at the 8th? No, it counts as the order and review at the 1st. And if you're out of town, patient has labs done, they're reviewed by your associate. No, you do not get credit when you come back from vacation if they're in the same specialty. That was done when they ordered it. So time, this is the second major change, and you can use, remember, we said you're going to be able to use time or MDM. But it's not going to be just time face-to-face now. It's total time on the same day. So that's what's changed. But the medical necessity for the level of service and time spent must be identifiable within the documentation. Just because you spend 60 minutes with the patient, you have to show that you really need to spend that 60 minutes. So MDM, there's no minimum time. Most claims are going to be based on MDM. But if your MDM is low and your time is moderate, you're going to use the higher one. But remember, date of encounter time is the only thing. So if you review it before the encounter or after the encounter on another day, it doesn't count. They've changed the times. They've gone from the 20 minutes to 15, 30, 45, 60 for the news. And the ones that you're going to remember are pretty easy, 10, 20, 30, 40 for your established patients. So you between 10 and 20, it's a 212. Between 20 and just less than 30, it's a 213. So remember, today, 50% of a visit has to be counseling and or coordinating care. In 2021, it's no longer. It can be total time on the date of count, which may or may not include counseling and coordination of care. So what can count is time. Well, of course, you're preparing on the same day for the patient visit. You're reviewing tests or other things that's pertinent to that visit. You're obtaining or reviewing a history from the patient. You're performing a medical exam. You're educating or counseling the patient and their family. You're ordering tests. You're referring a patient. You're documenting in your EHR. Again, this is very critical, though. If you type 2 words a minute and it takes you, it takes you 10 minutes to type in a paragraph, that's not considered time. You've got to use kind of the average time. So you've got to justify that time in the chart that's applicable. If you're a slow person getting that information in, you're going to have to downsize that amount of time that you take. And then if you do care coordination, or again, you interpret these results. So it can include, like I say, the pediatrics, talking to a teacher. It can discuss a discussion with law enforcement, or it can include if we have to call the patient's primary care or another specialist. What's not included is the time your staff spends getting your authorization. But if you have to get on the phone, this is related to the MDM, as long as it's on the same day as the encounter. Time used by your nurse to take a history is not included. Time by your staff to do in-house testing, EKG, all these things, this separate CPT, not counted. And then time spent that you're doing a procedure, not counted. So let's look at an example of that. Your nurse spends 5 minutes documenting brief history. You spend 10 minutes examining, taking additional history. You order a strep and flu test. It takes 20 minutes for your staff to complete. You go back in with the patient. They had a positive strep. It takes you 8 minutes to go over the results, write the prescription, and finish charting. The total time you spent is only the 10 and the 8 minutes, 18 minutes. That's a straightforward 99212. Now, if you go back to your MDM, it's low. You've got an acute uncomplicated illness. You've got no data, or you've got those 2 tests, whatever way you want to count that. But your decision-making is moderate. Whatever you do here, your MDM still comes out to low. So low is higher than the time with straightforward. So you would use MDM over time. Remember, you have a choice. You can't double dip. You can't count the time that you discuss things with your mid-level or the time that you both see the patient together. So a patient comes in about resolution of the otitis. The nurse practitioner spends 5 minutes reviewing the chart, notices the patient's unimmunized. So they go in, do the brief exam for the resolving otitis, but then they counsel the patient for 10 minutes on the immunizations. Well, then the mid-level goes and talks to the pediatrician for 5 minutes. So they both go back in, try and talk the patient into getting the immunization, and they spend 10 minutes doing so. They refuse the immunization, so the nurse practitioner or PA takes 5 minutes to finish up documenting the encounter. What's the time? Well, it's the 5 minutes they started reviewing, the 10 minutes that was initially spent to do the exam and counsel, and then the 10 minutes that they both spent together with the patient, and then the 5 minutes for documentation. It's not 20 minutes. They don't each get to be 10 minutes because that would change your level. Again, this is 30 minutes. So, you only count that 10 minutes for one person, whether 2 or 3 of you are in there. Same thing with a modifier 25 procedure. It's an identifiable separate service. So you don't count the time you're doing the procedure. Patient returns for elbow pain. They failed nonsteroidal home exercises, rest. You spend 5 minutes updating the history. You decide to do a joint injection, takes you about 10 minutes. You spend another 5 minutes documenting, giving them instructions. Your total time here is only the 5 minutes and 5 minutes, 10 minutes, or it's straightforward. So if you're using time, your modifier would be 0.25 on a 99212. But remember, MDM, problem, it's still acute uncomplicated illness. There's no data, and the risk is low. So that's a 99213. So again, you're going to choose MDM over time. Now, this happens to a lot of us. Patients sometimes have limited communication or ability to be examined properly. You've got a patient came in with a mass on the back getting larger. You spend 5 minutes reviewing the patient's chart, and then you get in there with the patient. Well, You get some more history. You find out unfortunately there's language issues, so you're having to get the history from the daughter. And then the patient is not very mobile, so they can't get into position very easily. So you have to get them up on the table, then you got to get them down. The whole thing takes 23 minutes, but your diagnosis is a lipoma, no treatment. You spend another 5 minutes charting. Well, you have spent 33 minutes with this patient, 5 minutes reviewing, 5 minutes charting, and 23 minutes face-to-face. Now, your MDM, though, is low or straightforward. You got an acute, uncomplicated, or a very minor problem that requires no treatment. So you're not going to use MDM here. You're going to use your time, 99214, remember 10, 20, 30, 40. So it's between the 30 and 40. That's your 214. And you can document this. Even though the problem was very straightforward, you use time and you get a 99214 rather than a 212 or 213. Again, this just shows an example. You have to do everything on the same day. If you did not talk to the physician or the specialist on the same day, or you reviewed the test beforehand, you can't count that time, and that will decrease your level of code. If you did everything on the same day, you get credit for the 50 minutes, rather than if you did the review before and then you talk to the specialist after, you'd only get credit for the 30 minutes. So if you use time, should you document a time range or actual time? You want to document actual time, and don't round everything to 20, 30, 40. Make sure it's 25, 28, whatever it is. And if you're using time, do you need to list all the activities? Not necessarily, but you have. This is kind of the example they gave. I spent 42 minutes caring for the patient today, reviewing labs, records from another facility, seeing the patient, documenting in the record, and arranging for a sleep study. So a patient presents for depression. They're doing actually pretty well in their depression. You review the last couple visits from the psychologist, because they're now transferring care back over to you. You review the labs that were done. They're working, but now the patient comes in and they start talking about some other things with some personal relationship issues they're having, and they wanted some counseling. You spend 25 minutes doing that. Even though the depression has been pretty stable, this is obviously impacting that to some degree. So you suggest, hey, we're going to have to redo a psychology referral. So you spend 10 minutes doing that referral, sending an electronic prescription, another 10 minutes finishing up the encounter. You spent 5 minutes reviewing. You spent 10 minutes documenting. You spent 10 minutes referring and 25 minutes with the patient. That's 50 minutes. 50 minutes on the date of an encounter for a follow-up patient is a 99215. However, if you were going to use medical decision-making, you'd have a chronic illness with a mild exacerbation, you reviewed the test, prescription drug management, you would only be billing a 99214 if it was a new patient at 204. So this is where you choose time over MDM. I want to go over a little bit about documentation because this is critical. You do not need to document everything like we've done in the past. So you got this patient, CHF, coronary disease, chronic kidney disease, stage 3, comes in with peripheral edema, some dyspnea on exertion, increasing orthopnea at night. He brings a copy of his last labs and his cardiology notes. He just moved here 6 months ago, so he hasn't been taking his diuretics like he's supposed to. He's been trying to stretch them out. So he has some pedal edema, some crackles, O2 sats are 94. So yes, he's had some exacerbation of his CHF, but mainly because he didn't take his medicines. He seems pretty stable. Since you don't know him, you call his cardiologist up and said, yeah, he's stable as a rock when he's on his medicines usually. So you both decide, hey, we're going to increase the diuretics. We're going to check an echo just to see if anything's changed and monitor the BMP. So you order the echo, you order the baseline lab so you know where you're starting from with potassium and kidney function, and then you increase the Lasix for a couple of days, but you order the BMP for 1 week to monitor the renal electrolytes. This encounter takes 40 minutes. Now, for a new patient, you got to get up to 45 minutes to get a 99204. So this is actually a 99203. So it's the 30 to 45 minutes. However, let's look at our medical decision making. Well, I wouldn't call this a severe exacerbation. If a patient is stable usually and they're not taking the medicines, that's probably one chronic illness with mild exacerbation. But we did review all those tests. We reviewed the 2 records from the previous physician and then we discussed it with the cardiologist. So we have met 2 categories in moderate. 2 categories is a high level of data review. We did the drug therapy. We're doing outpatient diuresis. We're monitoring their kidney function. So you've got 2 of the 3 in high. So this actually, rather than a 99203, is a 99205 by medical decision making. And you know those big notes that you usually have to dictate, well, this would actually suffice and pass an audit. You basically said, hey, they're here for CHF. You explain a little bit about the problem, not taking the diuretics. You give some brief review of systems. You put their vitals in, things that are pertinent in the physical exam. And now you have to document your medical decision making. Well, you discuss with cardiology. That's category 3 under data. You reviewed these 3 tests. You reviewed the cardiology appointment. That's 4 points. That's data category 1. So now you've got the 2 of 3 data documented, and you're checking the BMP. So that's your drug toxicity. That's your risk. So now you've got 2 in the high. You've documented all that, and that note right there, brief, and that would actually satisfy a 99205. Another brief example of this, just patient comes in for follow-up with their hypertension, diabetes. You review the labs done before the day of the visit, the CBC, the CMP, the hemoglobin A1C. You listen to their heart and lungs. You refill their medicines. Tell them to come back in 4 months. Counter takes about 15 minutes. By time, between 10 and 20 is 99212. But under medical decision making, this is a moderate. Again, you've got 2 or more stable illnesses that you're dealing with. You reviewed all of these tests, and you're prescribing medicine. So again, by this one, you're going to use the MDM and not the time. And your documentation, again, you're showing the 2 stable illnesses, you're showing the data that you satisfied, you're showing the prescription management, and then you filled in some pertinent history and exam and what the patient's going to do. So this, again, you don't have to cut and paste all those things, all those review systems. This would satisfy your 99214 visit. Remember, other people are going to use this, so it's important that you do document more than just what you need. In some cases, you got specialists, you got legal, continuity of care, RAF, other things like that. Remember, if you're listing things for RAF, because every year they start over, it's imperative that you don't count that in your medical decision making unless it's pertinent to the problem. Again, it's a comorbidity with the decision you have to make. But you can list it like their ostomy or their amputation or some unrelated thing that they have an illness, but it's not related to what they're there for. You can document, do all that, but do not include that when you're doing that for RAF purposes in your medical decision making. Prolonged time, this is what's changed. It does not include any times performed by your clinical staff, but it does include now, everything before had to be face-to-face. It includes face-to-face and non-face-to-face. We've gotten rid of the old codes for this. The new code, make sure your EMR has it, is a 99417, and it's only used on the same day as you use a 99205 or 215, because you're only using it when you extend the visit past what's allotted for these 2. So 74 minutes is the top limit of a 99205. 54 minutes is a 99215. So for every full 15 minutes, not 7 minutes, not 14 minutes, every 15 minutes, you would bill one of these 99417. So again, if you go over by 20 minutes over those limits, then you're only going to bill one 99417. If you go over by 32, you're going to bill 2. And this just shows you a little bit how that works. Again, you're only going to do full 15-minute increments. Now, a lot of you have used the 354 for extended visits, and again, it's for the first hour. And the limit there is if you went to 31 minutes, you could bill for the whole hour. You cannot bill these codes on the same day now that you bill these E&M codes in this 99417. Same thing with the non-face-to-face. Remember, your 99417 includes face-to-face and non-face-to-face, so you can't bill these anymore on the same day as that encounter for extended time. However, a week after you see this patient, a pile of records come in. You got to spend 45 minutes reviewing these records. Well, that's not normal. So that is something that you could bill this non-face-to-face code. Again, it's not on the same day as the encounter. So if you reviewed those on the same night as the encounter, you couldn't do it. But if you reviewed those on a separate day, you could. This is the code that all primary care needs to know for Medicare patients, G2211. There's still a lot to be determined and announced, but I'll give you what has been announced so far. It's going to be reported on as an addition to your newer established office visits. It can be used for all level of cares, and specialists can use it, but it's mainly, I think, for primary care or those people that do a lot of E&M coding. It describes the work that we are associated with visits that are not part of the ongoing, that are part of the ongoing comprehensive care that we provide to our patients for either a single serious or complex condition. Now, CMS has not released the actual values of this, but the work RVU is about a 0.33, so that's at least a $10. And then if you add in the other parts of the RVU, this thing's going to be somewhere probably 10 to 12, could be up to $15. But it's for every E&M code. So Medicare said this 2 weeks ago. They assumed that we would add this code on for 100% of the visits. Then they came back and quantified and said, well, probably 90% starting January 1. So basically, this code is pretty much going to be billed on every patient visit that you see for Medicare that's not a physical. It's an only for E&M codes. And the reason is, even though I'm going to show you in a second here, they've actually increased the fees. for E&M codes, they still don't feel that primary care gets the due we need for the total care coordination we provide. So why would we use this code? Well, it's for furnishing service to patients on an ongoing basis that result in comprehensive, longitudinal, and continued relationship with the patient. It involves the delivery of team-based care that is accessible, coordinated, and integrated with the broader healthcare landscape. So if you understand RVUs, that's how your reimbursements are calculated for Medicare. Each RVU right now is worth $36 this year. Your RVU is a combination of a work RVU, a practice expense RVU, and a malpractice. CMS has approved these changes that's going to increase the work RVUs for the new and established office visits. The new is going to go up by 10%, the established by 30%. So what they're doing, though, is they're decreasing the conversion factor by a little over 10%. And they're going to decrease the practice expense also. So they're basically taking money away from the people that do a lot of procedures, a lot of things that aren't E&M intensive, and giving it to the people like ourselves that do a lot of E&M codes in primary care. So it's going to hurt the specialists and other people that do a lot of these procedures, but the reimbursement changes are going to be uneven. So finally, I think primary care is being recognized with the care that they give that's not included in just the office visits that we bill for. As I said, they're going to increase this by about 10% for the new office visits, but they're decreasing the value of the RVU. So actually, your new office visits are going to slightly go down. The big change is going to be in your established visits. You're going to see anywhere from a 10 to 14 to 15% increase in your 213s through 215s. And again, this doesn't include the fact that you're going to add on that E&M G2211 code of $10 to $15 for each visit. What they had proposed is this flat rate that they were just going to pay us the same rate if we built a 212, 213, 214. It was going to be $90 or $130. And that, with COVID and other things, they decided to go ahead with just the increases. So we're going to get the increases that I went over. But this shows if they would have gone to the flat fees, how most practices would have probably got hurt, because a typical practice like this, billing this many 214s and 213s, was actually going to be less, $6,000 less than they were the year previous, as opposed to with those fee changes, they're going to be much greater. So what do we have here? Well, we've got January 2021. We've got these changes that go in effect for all E&M codes 99202 through 215. So the MDM and time changes take effect. We've got the codes that have been added and deleted. You've got your 99201 that's eliminated, your 99417, which is your additional 15 minutes, and then you've got your G2211 that's the E&M code mainly for primary care or for continuity of care. And then again, we've got the history and exam, which has changed. We no longer have to rely on the history and exam for impacting the level of care. It's only medically appropriate documentation. And the big change, of course, is you get to choose between MDM and time. So I hope, again, I ran through that kind of quickly. This is recorded so that you can go back and forth and play it back and hopefully get some useful information out of it. Remember, it's your clinical judgment that makes the final decision, and each patient is unique. So I hope you all have a great holiday. And if anything, if you have any questions, you feel free to email me. Take care and good night.